And I pressed him for a while, trying to get a percentage of maybe his patients that he would normally see. And he was very wise to not give me an answer for a while. And then he kind of threw out the 25%,
Yeah,
and that was just based on, okay, at this time in my career when I was seeing, say, out of 50 patients in a week, that type of thing, he mentioned around 25%. What are your thoughts about that?
yeah. So yeah, I thought he was being very honest there, and that he's very trained in it. He's going to test for it. He is appreciative of other schools of thought, certainly as a manual therapist. And he talked about having some McKenzie training. Um,
Mm-hmm.
it's going to be higher in his subgroup of patients than someone who's seeing acute or subacute patients. So
Mm-hmm.
he's seeing a patient population that's more chronic. So, maybe I'm doing uh, uh, more strategies geared towards pain neuroscience education, movement safe pain, neural mobilization, be it sliders or tensioners, aerobic conditioning to address that population. His approach maybe to help that patient break through that pain cycle through, addressing that trigger point. But I could bet if he addresses that trigger point and now that person's moving and feeling better, they're on the road to getting better.
Mm-hmm. Yeah.
It's a
Yeah.
different strategy than I'm
Yeah.
trained in or familiar with. But I would guess those patients, if if they're feeling better, whether it be manipulation or dry needling or repeated end range, and they start to believe that they can move better, and you have that relationship with them, that's going to help. That's
Mm-hmm.
because that's a key, right? Getting that person to move, who's either fearful of moving or reluctant to move or can't move. Once we get them moving again via whatever intervention we can offer, that's important. Then the key is doing it at a high level. So that person who's skilled in manipulation, has great handling technique and great relationship with the patient, they manipulate that person who's appropriate, and they move better and feel better. They're gone. They're on their way. We find a directional preference. They're on their way. You do dry needling. They're on their way. So I have a graduate who's the head of sports medicine for a professional hockey team, and he was exposed a lot to MDT at Damon,
Mm-hmm.
and had taken A and B, I think, as part of his at the pre-professional level, professional level, and had that foundation. And he told me, I had a conversation with him recently. He told me that when he's got a hockey player and they have an acute muscle injury, if they're asking for dry needling, he'll dry needle them. They're back out playing the next period. So
Mm-hmm.
he sees that immediate potential for getting that person who's motivated, has low fear, getting right back on the ice between periods via that intervention.
Right. Yeah.
So different population, different subset, different environment, different type of person, patient. So, you know, in that instance, that's quite different than with Joe's patient subset. But herein, that opened my eyes. I was like, wow. And he said, and there are certain players, it's related to cultural differences too, who are not afraid of being stuck with a needle, and they're ready to get going next period.
Uh-huh.
We've seen patients who gravitate toward manual procedures such as chiropractic or osteopathic because they want to get back to work the next day, or they want to get back to playing sport, and they get the manipulation, they're on their way.
Mm-hmm.
Now it may come back, it may return, but that is a different subset of patients. So I think the key is all about classification.
Mm-hmm.
So gathering as much data as you can within a reasonable amount of time, testing what you think is most important and relevant. Joe talked about test retest, and how many times we've talked about that with MDT. Going back and looking at that activity limitation, or that um, activity the person describes as being most provocative, and retesting it and seeing if it's changed.
Mm-hmm.
And when that changes right before the patient's eyes and they can feel it and see it, they're bought in. then there's that therapeutic alliance, and they're probably going to have a good outcome.
Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.